If you go online today, you'll see many companies are already out there delivering counseling, delivering psychotherapy, delivering medication management with MDs, but doing it in ways that are not legal or ethical. They're going across state lines. They're delivering anonymous care. Could you imagine? As licensed professionals, we are mandated to report abuse, correct? How could you do that if you don't even collect the name or the address or anything of the people that come to see you in the name of reaching folks? My interpretation of that is it's in the name of getting more people to ring your cash register. You see, so if you get more people to come in under the cloak of anonymity, then you'll make more money. But the clinicians that you hire now cannot do their jobs because your system does not allow them to collect names and addresses of people. So if they hear of abuse, well, I couldn't do anything because I couldn't report them. You see, it's our job, though, in the face of this retooling, to understand the law and the ethics and not take jobs like that. And most ethics codes, and I speak to all of the different associations and groups in behavioral care, so counselors, social workers, psychologists, psychiatrists, even behavior analysts now are coming on board, and some groups are getting licensed in some states. I speak to all of those, and I've looked at all of their ethics code, including MFTs. I am an MFT, by the way, and a psychologist. So I've studied a lot of that. And they pretty much all say the same thing when it comes down to this issue. It's that if you are being employed by somebody who's asking you to operate in a way that's in violation of your ethics code or of the law, your job is not to say, yes, boss, but it's to say, I'm sorry, I'm a licensed professional, and I can't do that, and here's the ethics code that says I can't. You see, so if you want me to stay here, then I need to be able to follow my ethics code. That's our obligation, because those ethics codes and those laws have been developed to protect consumers. So it really becomes a consumer protection issue. So when you go online and you look at a number of the services that are out there, I just want to encourage you to think about, yes, it's wonderful that we're developing new ways to do things. It's wonderful that the world is retooling. We all have these great little computers in our purses, in our pockets, our little phones. But what are we doing when we're trying to uphold a licensed practice through these devices if we're not going to be following the law and ethics codes? So what I did years ago was to come up with a model. I came up with this in the year 2000 and called it the Online Clinical Practice Management Model. Now this is before cell phones. This is before Skype. This was along about the year 1999, the year 2000. I had already been working in the field now for 6 years. I've been invited to participate in 12 standard and guideline writing committees, work groups, and task forces. So in sitting with these different groups, this was the Counseling Association, Psychological Association, Telemedicine Association, in sitting with these three groups and listening and working shoulder to shoulder with other thought leaders in the field, I learned a lot. And what I learned is that most of it's the same across all these disciplines, is that we have to abide by the law, and ethics code is built above the law, right? So we have a state that has some laws. We have a licensing board that then interprets those laws and comes up with rules to be followed in that state. That's a regulatory board. They say, okay, you have to do things like write notes. Many state licensing boards say you have to write notes in a behavioral type consultations or a therapy session. Well, then the ethics code comes along and says we're a step above the law, right? So you have to follow all the law, and your notes have to include certain things like, and they'll go into more detail about what you have to do. A guideline is even a more precise look at whatever the thing you do. So there might be child custody guidelines. There might be record-keeping guidelines, and depending on the association you look at. Well, let's say record-keeping guideline goes into even more detail than the ethics code does or the state law that's underneath it. So you see how there's a gradation there that goes up, that says law, ethics code, guideline. So in looking at all of that and coming up with this model, I realized there's a ton of stuff for people to know, and most people will never do that. They will never, once they get their degree, go study all of that just to be able to practice online. So I thought, we're going to boil this down. We're going to boil all this legal stuff and all this ethical stuff down to 7 principles that form the core of this model. So the first is training. You're not supposed to practice in any area if you haven't had training. So let's say you are a recovering alcoholic, all right? You have been sober 20 years. Does that give you the right to go practice now as a drug and alcohol counselor? The answer is no. You're all shaking your heads. No. Right? You have to take a course. What does the course or series of courses teach you? It teaches you etiology, how people get to have alcoholism as an issue. Right? It teaches you possible treatments for those particular types of etiologies. Right? So if you have a genetic predisposition, if you do different things happen, well, here's what you need to do to take care of that. So treatment models are based on how you got that way. Right? So that's what we need to do with telemental health, or however you want to call it, behavioral telehealth, distance counseling, telepsychiatry, telepsychology. Every group has their own little spin on this, but it's pretty much all the same thing. How do you do whatever you do with whatever population you want to treat, but do it through a monitor or do it through a camera? You see? So that's the trick. Because when people come into your office, you can't walk behind them to get to the chairs that you're going to sit in. In my office, when I go to meet somebody in the waiting room, I introduce myself, and then I let them pass in front of me, and they walk in front of me. What am I assessing as they go into my office? I'm assessing, are they walking okay? If they're starting to stumble, or they can't quite navigate my door jamb, they trip up there, or they can't quite sit down, they can't slide themselves and sit into my chair, what comes to mind for me? I start thinking about, well, is there a cognitive disorder here? Is there an ambulatory disorder here? Are they inebriated? Do they need to be medicated? Do they have some type of physical disorder? Or are they overly medicated? Sometimes people are overly medicated, especially with some of the more intense neuroleptics. They can be overly medicated. So just that simple little walking through the door, which in most of our fields we don't even have a name for, but the psychiatrists call that a gait analysis. Okay? We do that. We automatically do that. And then let's say we decide, and we kind of sniff around, I do smell alcohol here. Or, I'm noticing that the iris in that person's eyes is very constricted. What does that tell me? Now I need to start right there. Because that is a very important issue, is if they're somehow intoxicated, sitting right in front of me, I have to start there. And at least know in that session I'm going to be talking about that. When you're working online, you can't do any of that. All right? Most of the time, you cannot zoom in to somebody's iris with a camera. You see their full face. This woman on this slide appears bigger than they probably would on your laptop screen or certainly your cell phone screen if you're going to be using cell phones. So how do you tell if that iris is constricted or not? Really tough, see? So a lot of the stuff, you can't smell them for sure because they're they're really far away from you, right? So whatever that distance is, it's your job to know how to bridge that. Because if something goes wrong, the people judging you will either be your peers in a licensing board pulling you in for a licensing infraction, or there'll be folks in a civil court and it'll be your peers, the plumber down the street, the shopkeeper, down at the mall. I mean, these kinds of things. And they will not say, oh, you were practicing online and you couldn't see if that iris was constricted? Because we know what that's like. They're not going to say that. They're going to say, you know what? Someone with your degree and your licensure needed to assess that properly. And you didn't do your job. You're guilty, right? So it's our job, when we start deviating from the standard of care, it's our job to fill that gap. And it is impossible to do that adequately if you don't have training. And all the ethics codes and all the associations require training for this type of thing, and they usually include it in one of their early ethical requirements. And that is called boundaries of competence. You have to have the competence to do whatever you say you're going to do when you offer that thing, that service, to consumers at large, clients or patients, whatever you want to call them. So if you don't have the competence and you offer that service, you're pretty much like the alcoholic who's been sober 20 years, has never taken a course, but by golly, you're going to hang a shingle and be that type of professional, drug and alcohol counselor. So that's pretty much what we're dealing with and why training is our number one issue here. Then, of course, there are referrals, patient education. You can't expect a regular consumer to know everything about counseling or psychotherapy without telling them, right? That's why we usually have an informed consent process. Well, once you get a technical overlay, all the bad things that can happen with the email that you sent them, or all the ways in which the video that you're now operating in can be hacked into, passwords stolen, identities stolen, there's all kinds of things. If you don't tell them that, then how are they going to know? They're not reading up on this stuff, right? So it's up to us to tell them. So that's patient education. And then all the laws, very important. A number of laws come into play. One of the more important issues is assessment. How do you assess people? So we had a little example here about alcohol and how do you assess with a gait analysis. But if you're trying to do psychological testing online, and many people do that, a lot of counselors even are doing more psychological testing these days, how do you do that in control for the environment? Because there are many requirements involved in administering psychological tests. If you think about how we normally do it, we generally sit around in our offices, someone comes in, and we leave a clipboard up. Many of us have done this for years, a clipboard up in the waiting room, or there's an admin or somebody who gives them, a receptionist gives them a clipboard with an intake form, the HIPAA document, and maybe a Beck depression inventory or an anxiety scale. If you're really robust about this, you might put an MMPI in there, although first session you might scare them away. 565 items is kind of daunting for new people. But whatever your thing is, when you get people in the door, that is a standardized assessment process because they're sitting in your room. Now let's say you're trying to do the MMPI or a Beck depression inventory. An easy, what is a Beck, what's the BDI? 19 items? I forget, it's been a while. Yeah, something like that. You say, no big deal, just, send that to them. Well, how do you know that a spouse wasn't standing over them when they were filling that thing out and the spouse says, wait, that was not right. You don't feel that way. You're like this. Well, then the person taking the test could very well be somehow intimidated into, oh, okay, honey, and change that item. That alters the standardization of your testing administration. So many things like this come into play. So that's why it's important that folks understand if you'll be doing assessments online, what kinds of assessment, how can you make sure that that person at that other end understands how this needs to be completed, and they attest to the fact that they've done it that way before you start interpreting results, right? And telling them, oh yeah, you're massively depressed and whatever, So you have to be careful about that. The issues of direct care are very similar. I won't go into all of these details, but I've written 4 textbooks about this, so I can go on and on. There's a lot of information about how you deliver the care, the many clinical issues that are involved. And then, of course, the one that's near and dear to most people that like to eat, and that is reimbursement. We have to earn a living at all of this. This is not hobby material. This is actual serious business. How do you conduct it and then make a profit so that you can support your families and get what you need out of your lifetime? So what we start with, when we look at this model that we pull together, is a number of articles that, of course, we have to look for to understand what's reasonable. If you look at the studies that I'm going to give you a couple of, they're mostly focused on video conferencing because that's the area that has been researched since 1959. Okay, we've had almost 60 years of research looking at mental health. I'm not talking about cardiology here. We're talking about mental health, the treatment of people with mental disorders. And I just want to define that term for you. Mental health is a subset of behavioral health. Those of you that have been reading a lot of the recent material out of the U.S. government anyway, the substance abuse communities and the substance abuse disorders have now been combined with mental health disorders, and they are known as behavioral health, right? So this rings a bell for a lot of people. So when we look at behavioral health, if you stop and think about what kind of person comes to your average practice, is that a seriously mentally ill person? There might be some, right? But unless you're working in a specialized environment like an inpatient unit or some type of agency, community agency where there's a real specialized population, you could be dealing with regular people with regular problems. They have a kid who's bedwetting, who's 12 years old. Is that mental illness? It's not substance abuse. I mean, hopefully not, right? But a lot of the disorders that we treat in a general practice are not mental illness. They are problems in life transitions. They're adaptation problems, a lot of transition type problems. Somebody might have a chronic illness that develops, and they have to adapt to that, right? Does that mean they're mentally ill? No. But where does all that land? It lands in the behavioral health care's office. So when we start talking about these things, it's important that we understand we're not talking about only borderline or bipolar people or schizophrenic people. We're talking about people that have a wide variety of disorders, and all of the research that I'm going to show you applies to that wider definition. How do we, whatever the thing is, the category of people you're treating, how do you do that through technology? The one technology that has shown the test of time is video conferencing, because you're bringing in as many modalities as possible. You've got the voice, you've got the video, and the video allows you to catch a lot of the nonverbals. It won't catch the tapping foot that many of us Gestalt-trained people like to catch and bring into the session, but it'll at least help you see the person on camera. And it also, in some cases, allows you to write things out so that you can text some things. So the video conferencing, when you look at these meta-studies, I tend to cite meta-studies because they're a compilation of lots of little studies. And a lot of times they'll take very large numbers of studies and they'll cull it down. So this one, I can't quite see how many they started with, over 100. And then they boil it down to a few handfuls of studies that use the same terminology, that use double-blind kind of situations, that robust studies, things that are put together. Not what I like to call opinion pieces, where people kind of go off the top of their head what they think ought to happen out there in the world. So these are systematic reviews, meta-analyses, and this Buckhouse one I like in particular because it looked at a fair number of studies, and they came away with a statement that I'll just summarize, I'll paraphrase for you, that said any disorder can be treated through video conferencing, given any diagnostic category, given that the circumstances are right. Now, those, for the treatment, those words are very important. And you'll see a lot of the media do, grab the first part of that, any disorder can be treated through video conferencing. So I'm talking about the popular media, the popular press out there. They'll take a statement like that, and then they'll just throw that on the internet with things like, talk to your Skype therapist today. Well, they're not talking about using Skype. Most people understand Skype is not HIPAA-compliant technology, but Skype for Business now has come out. Skype for Business is a HIPAA-compliant technology, but Skype, the regular Skype that most people use, is not. And so you can't just take an article like this and then throw it out there with a headline like that and understand it fully. The other thing that we need to think about is, if you look at how these studies are pulled together, so these are some of the studies in this, the Buckhouse systematic review, they generally are conducted in university schools that pulls together a fairly large audience from the geographic area around the university. And they'll make contact with the physicians' offices and the agency, the mental health agencies in the community, and say, hey, we've got a study for depression or anxiety or whatever. And they'll help people get the word out with a very tight description of the type of client they want to have. And so those agencies and those medical offices will start referring people. And the studies will go on for a year or two as they gather enough subjects to have a reasonably powerful study. And what happens with the people that end up in that study is if all of a sudden they get suicidal or they have some type of breakdown and they end up to need more than what the study provides, maybe they need medication management, maybe they need inpatient care, then they get pulled out of the study and referred back to who sent them to the study, to the physician's office, to the agency, right? There's a support system in that community to help those people. Now, when you look at taking a headline like, see your Skype therapist today, right? That is appealing to anybody out there who has a video monitor. They can be in Sri Lanka, they can be in Istanbul, they can be in New York City, they can be in the house next door to you. And you don't know. But you also don't have the support of the community in Sri Lanka or Istanbul or New York, or you may have in your own community because you probably know your community resources. But as licensed therapists and counselors, you're not in a position to be practicing over state lines. So you'd be hard-pressed to know all the resources in all these different areas. So you have to be careful with these kinds of studies and understand when you're looking at a study like this that is documented research, understand where the research comes from. The other thing that happens is that the clinicians involved in these studies always have a manual to follow, and it is manualized therapy. There'll be a 12-session, 15-session, oftentimes cognitive behavior therapy format. And all the therapists do the same thing. So there's nobody sitting back at the end of their Skype monitor and saying, so, how are you today? And just kind of free-flowing. This is not a loosey-goose kind of therapy. This is very tightly monitored. You've got X number of things to cover the first session, the second session, third session. It's organized, you see? And that's very different than sitting around and chatting with people and charging them money at the end of the session. So when I'm citing research, I just want you to know what I'm talking about. There's very controlled studies, and there's a lot of support in the community. So this is one of the ones, the Buckhouse study. This one's a newer one. A couple is brand new, actually. Let's see what the year was in this, 2013. And so you see 755 studies, and out of those 755, they took 85. And they came out with the same type of thing. Here's the results. You can read that for yourself. I'm not going to read all these slides to you, but basically, pretty much any disorder in any setting, given the right controls. So inpatient, schizophrenic patients, right? Well, they're pretty well cared for. There's a lot of security there. If anything happens with the session, it doesn't go right, they're protected. That's our number one duty. Do no harm. Protect people. So when you deliver care, you have to make sure, number one, that they are in the proper environment for the type of disorder that you're treating. Oh, runaway slides there. I wanted to show you this about this last study I wanted to show you. Telehealth technologies for depression. Right, so this is for depression. And so now we're taking a subset. There are phone studies. If you look at this slide, you'll see the third column over. There's sort of a grayish box around it. The TC in there stands for telephone counseling. And then VC stands for video counseling. So there are many studies for telephone. And there are many studies for video. So I wanted to point this out for you too. Video is the most commonly studied, and has been shown the most effective, once again, because you have more to work with in terms of data. And then telephone is the next one. Now I'm going to shift over a little bit and talk about some of the Affordable Care Act changes that are going to make things look more appealing for distance counseling and telecounseling, online therapy, whatever you'd like to call it. But first, so now as I kind of project a little bit out into the future, I'm going to ask you to take a step back with me and look at what happened in the automotive industry, because this is a clear roadmap for where we are going with the technology here. And the Affordable Care Act is making it even more pressing that these changes happen, because it controls the money flow in all of healthcare. And our actions will follow money, because most of us have to earn a living, right? So if you look at the government's getting set up to change the way we work by paying us differently, then, and once you get that concept, then I want to ask you to step back with me into the automotive industry and see how that has changed what we do in terms of transportation. I know it's kind of a bit difficult thing to hold both together, but just bear with me on this. In the late 80s, Henry Ford made his first automobile. First one. That, let's say, is about 1880, somewhere in there. This is 1873, but by the time, it kind of got going a little bit, let's say 1880, just for round numbers. The internet started, for most of us, in the 1980s, right? So about 100-year difference here. We went from 0 cars on the face of this planet to many, many cars. Then along about 1908, the Model T was getting better and better. Look at what happened at about year 2000 and 208. We started getting faster speed internet. Technologies is reducing in size, coming down in cost. It's very similar to what happened with the evolution of the automobile and the transportation industry. And then we started getting cars with many more features. So here you can not only carry 2 people, but you have a whole seat in the back. Tires are getting softer. There's a windshield. And so they start adding bells and whistles here that make the ride more comfortable. Well, that's what we're starting to see now. In the 2015-16, we're going to see many more adaptations. Phones are getting smaller. Those phones can do more and more. Our desktops can do more and more. And what will soon start happening is that we will have what has been known till this point as peripherals, but now they're going to be known as wearables, where we have a Fitbit or a Jawbone or those kinds of things are bringing more measurements available from our bodies into things that we'll be able to read on our cell phones. So it won't just be how many steps did I take today, but what was my heart rate variability, what's my EEG, what's my galvanic skin response. When I put all of that together, what does that mean in terms of my emotions right now? Gee, I thought it was nice, cool, calm, and collected, but my insides are off the Richter scale. Okay, something's wrong. And so we won't be able to get away with so much denial and rationalization once we get our own measurement of what's going on with us. It's a direct parallel to what happened in the automotive industry. Now, I'm not going to give you 15 slides on this, although I have some. But I do have a little video on YouTube about this, and it's about a 20-minute video, and I give you like a one-to-one comparison of where we've been with cars and where we are today. So you can go look that up. It's at TMH channel, so it's our Telemental Health Institute channel. But if you just imagine now a 7-lane freeway, I just drove up from San Diego this morning, and there are literally at some points there are 7-lane freeways. From what you see in this picture, this is a dirt road in roughly 100 years. This is what we're going to see in behavioral health care in the next 100 years, is our work will be revolutionized in a way that many of us don't even anticipate. And what a lot of people don't realize is we, the trained clinicians, are in an optimal position to work with the technology industry to make these changes, adhere to the values of the professions we all love so much that we've taken literally years of our lives and often hundreds of thousands of dollars to study and to understand and to get licensed to practice. So who better to lead the technology industry than us? And if we don't do it, stop and think about who will. People who may not have our values at stake. You see? So that's why I show you this, to just say, this is not kind of pie in the sky, once you're dead and gone, we're going to get this. In a very short amount of time, look at what happened with automobiles. It literally reshaped the surface of the planet because we have so much black tar on our planet that it is being attributed as one of the sources of global warming. That the sun is, the heat is being absorbed so much by all the asphalt on the planet. And when you look at the corridor between San Diego and LA, you stop and think, that's a lot of roadage that's gone in there. I mean, what have roads and cars ultimately done? They not only have done that, but they've also allowed many people to no longer live in small condensed cities, but suburbs came up because we had cars. Folks get to work in the morning and night, so all this transportation literally changed how we live and work, and we're just starting to see this in mental health care. A lot of the predictions are that right now we are at a hockey stick curve. You ever hear of that? Anybody ever hear of this hockey stick growth curve? I'm going to do it backwards because I'm facing it. A hockey stick is shaped like this, right? And then it goes up. Okay? So what we can see is a slow progression upward, right? Of change. Things are changing. And we're seen as being right in the elbow of that hockey stick, where now it's going to ramp up really quickly. Why? Because now we have computers who can create computers. We have computers that can fuel our thinking and make things happen so much more quickly that the engineers of the world can now ramp this up. And what that also means is that much of this care can be delivered by code and no longer people. Code can be controlled. We can find an algorithm as to what's going to help people change the most, plug that in with artificial intelligence, and have avatar therapists. And that's, for many people in the IT world, that's what they see happening. And I go to these conferences regularly in San Diego, because there's about one a month in San Diego. And that's what they're all talking about. So this is crucial that people in our professions understand that we're at a time when if we do not understand what's going on around us, then I want to invite you to take a half hour and go to the internet and type in online therapy, just those two words, and look at literally a half hour's worth of stuff there. You'll see a wide range of things, a bunch of people doing email therapy, not quite aware of the fact that there are state lines and licensure laws and that kind of thing. And then you'll see a lot more of the front end of it where we have business taking over and they're not adhering to our values. So one of the great pleasures I have is to travel around and give this talk and say to my colleagues, we can do this right. Many people come to me to try to get this information, try to find out what the values are, how to manage risk, how to do this type of work legally and ethically. And I can't do it all by myself. I encourage you to join me in this. If you're young or you're interested, even if you're not young, if you're interested in a new avenue of pursuit, this is ripe and it really, really is needed. So feel free to jump in. Also, just as an aside, the paychecks for doing this type of work as a content expert are much higher than a psychotherapist. So if you're looking at where you want to go and what you want to do with your lifetime, sometimes calling yourself a licensed therapist will bracket you in terms of your income level. But if you think beyond that and move into what can I do with my mental health training in the technology world, you'll see that people break out of the usual labels and there's a huge array of different types of things. As a matter of fact, the fourth one I just finished, I just finished that in January, was literally that. It was, I can't remember the exact name of it, but I'll get it to you in terms of the resources, but it's how clinicians with a mental health degree have now been earning a living in the technology world. And we managed to get 30 different chapter contributors to this book. These people that I just run into and I know, and of course we had to get 60 people to agree to it, and then we got 30 people that actually gave us the book chapter. But they're very short 5-page chapters, so you can see, wow, what do these people all have in common? What were they all thinking? And what's the upside, downside to their job? So there's a tremendous future in this. I just want you to think about the possibilities for yourself in whatever specialty area you have. So it doesn't have to be just behavioral health. It can be whatever specialty that you have. There's somebody out there that needs that type of expertise that's developing some type of service using technology for it. So with all of that, I want to show you what the numbers are in this country. And I know that many of you are from foreign countries. And at the Institute, we have people from 39 countries. So we've trained a lot of people. I've got to hear what's happening in foreign countries about building up the infrastructure of the country for telehealth, to support technology, to deal with behavioral care. But I'm just going to give you the numbers in the U.S. There's a tremendous need for more services to help with people who have serious mental illness. Of all the therapists we have in this country, most people are not getting treated. So we can't do it all with live people. And the live people we have can be better allocated to deal with what we have as well. Serious mentally ill people are approximately 13 million in our country, 5.8%. Children are about 8 million, about 10% of the people with serious mentally ill, mental illness are children in this country. It's just amazing. 1 out of 10 kids is struggling with some serious disorder. Overall, about 25% of our population deals with mental illness, and that means an Axis I disorder that is diagnosed in any one calendar year. 1 out of 4 people. Some studies say 5, but whether it's 1 out of 4 or 5 people, that's a boatload of people, and they're not all going to see therapists. We are not allocating our resource pool as best we could. That's why the federal government started funding mental health care in 1959, because smart people are in the government. A lot of people like to criticize the government, but a lot of smart people work for the government too, and they could see this need building, particularly in rural areas, that there were many people that lived far away from offices. They couldn't even get to a primary care office, never mind a mental health practitioner, behavioral health care person. So 1/3 of adults and 2/3 of children with serious mental illness receive no services, 0 services. That's not okay. 2/3 of others with mental health conditions, not even serious conditions, but 2/3 of others with mental health conditions receive no care. Now, if you think those numbers are bad, let me show you substance abuse numbers. Approximately 24 million potential cases a year. That's drug and alcohol, right? But only 1/10 of those people get care. So more than 90% of people with substance abuse in our country do not receive any care. Care that is received comes principally from grants, and more substance abusers are housed in our prison system than are treated in facilities. Now that is a sorry statement for the United States of America. More people get care after they get incarcerated than they do without incarceration. We need people to focus on substance abuse in this country. And the federal government, with the Affordable Care Act, is focusing directly on these problems in our space, right? So the Triple Aim, you've probably heard of it, Affordable Care Act trifecta, is improving individual experience of care, which is access. Okay, you can't get to the doctor, you're not going to have any experience of care, or a clinician of any type. Improving health of populations, the quality, so they want to improve the quality of care, and reducing per capita costs, which is just general cost of health care. So the Triple Aim is increase access, improve outcomes, and decrease costs. And this, by the way, I wanted to give you the original source for this. So you'll see a lot of my slides have the reference at the bottom. This came from Berwick, Nolan, and Whittington back in 2008. Not even that old that the Triple Aim was identified. Well, the government has changed the wording around a little bit, but this is the original document that cited that. So the Affordable Care Act came along and changed universal insurance coverage. So there's parity. So behavioral care now is on par with general health care. No pre-existing conditions. They are also fostering medical and health homes, meaning people need to stay at home. It's cheaper to leave people at home and provide the technology that they need in the home. So that is very important for us if we're trying to think of where to get jobs. Look at, if you're looking to find a job, look at your local community and do a search on the internet for medical homes or health homes. And go talk to those people as a behavioral health practitioner. How can I help you? What work do you have for me to do? And jump in there and do it. And then 10 years from now, you'll be way ahead of the pack. 5 years from now, you'll be way ahead of the pack. Because right now, the masses of behavioral health people are doing what they did 30 years ago. No difference. But the government has not stayed put. They've moved ahead. It's just that mental health care, behavioral health care, is the last one to come aboard with these changes in how we work. If you go to a cardiologist's office, more than likely they will give you a device to wear in your belt with sensors to put in your chest. And if any of you know any cardiac patients, they measure, they have already moved into the technology age. It's us in our profession. We're the last ones at this table. Then they're also with the Affordable Care Act, disease prevention and health promotion. And the focus is on achieving recovery. Let's think about that. Recovery. What is recovery? Recovery means I'm not just maintaining. It means I'm trying to get back to a state of health, a state of being able to function. Not that I'm over it, right, but that I can regain the functioning I had at some previous level. And the other thing is resilience. If you stop and think about this, it's a depathologizing of the vernacular that we hold so near and dear to our hearts, our DSM categories. Right? When you stop and look at that, it is pathology from one end to the other. There's no positive look at that, but then we saw a whole uprising of positive psychology, which was a backlash to all the pathologizing we had. Positive psychology only goes so far. Now the government is embracing the term resilience, which means let's teach people how to strengthen their ability to recover in a shorter amount of time. Because the sign of health is not that you won't fall down, that you won't be stressed, that you won't get a cold. It's how quickly you can recover. And your speed to recovery is a function of how resilient you are. It's that simple. So that's the model that the government is embracing, that they want to help people get more and more on board with what does it take to be resilient. Well, you know what? Kind of the basics. You need to sleep, you need to eat right, and you need to exercise. You need to take care of the house here. Keep yourself in order so that you're functioning. And if you can't do that, then you will be more likely to suffer some type of impairment that you won't be able to recover from so easily. So that's the core of the Affordable Care Act and what I interpret it to mean for us in behavioral health care. So what does it mean for us as counselors and psychologists? It means that there's a greatly increased focus on substance abuse, on mental health, on life-threatening or expensive health-related conditions. So the 4 top categories: cancers, COPD, heart attacks should be in there, and then infectious disease, of course. Then another thing it's going to mean is that a lot of funding that we've gotten for private agencies will be taken away and rerouted back through the Medicaid system, which here in California is the Medi-Cal system, right? So a lot of the little funding sources that have kept many small behavioral health agencies alive are already drying up. And those monies are getting rerouted to support more health information exchanges, more of the federally qualified FQHCs, federally qualified health centers. And now we're going to see, this was just announced about a month ago, behavioral versions of federally qualified health centers, and they're called Federally Qualified Behavioral Health Centers, FQBHC. If you haven't looked that up, look it up. One of the things we do at our institute is we have a free newsletter, and we roll it out every week because I take the top 6 to 10 stories in the news. So I track the news. And I've been watching for this FQBHC for about 4 months now because I heard about it in the spring at another conference I went and spoke at. And sure enough, that was a SAMHSA speaker that mentioned it at that conference, but sure enough, it came out, I think about 2 weeks ago, that we will now have there's a designation that the federal government will give to community mental health clinics that meet the criteria for these federally qualified behavioral health centers. Right? If you meet the criteria, then you will get money from the federal government. Well, these Medicaid systems. So the money's leaving the small agencies, and they're going to be rerouted into these federally qualified behavioral health centers. If you don't understand the money flow, and you try to go get a job, guess what can happen? This is a very big time of change. Want to be where you have some job security if you hope to earn a living in this field. So that's part of the reason I'm trying to give you this and help you see a lot of this ties to technology, because you can bet that those federally qualified behavioral health centers will be tech-enabled. And if you have technology skills, you will stand apart from other people who are just your average person coming through. So if you're techno-savvy, if you understand the law, the rules, or regulations, you'll be in much better position to be getting a job. And be more valued when you're there. Kind of makes sense, right? So the other thing is that the referrals for patients in these systems will generally come from primary care docs, which are usually who staffs the federally qualified health centers, by the way. The primary care physician has been moved in the entire scheme of things to be the hub. That physician will then refer out to everybody, all the specialists, and that physician is now also mandated to have a behavioral health care practitioner on staff. Because the federal government finally recognized that behavioral health care is important. Could have asked me that, or any one of us, been around for a few decades. Is behavioral health care important? Yeah. So they get it. Because when you look at the 4 top chronic illness categories, 70 cents for every dollar spent in this country is spent on chronic illness. Cancer, heart attack, COPD, it's a lot of smokers, chronic obstructive pulmonary disease, right? And diabetes. Diabetes is the most expensive, right? 70 cents of every dollar spent in this country is on people who have those 4 conditions. 30 to 35% of those people have a diagnosable mental health disorder. Do they need us now? Does the government need us now to keep these healthcare dollars down? Big time. So they just put this as a requirement when part of the Affordable Care Act is that every primary care office has to have a behavioral person on the team, and they're going to be operating as a team. So that behavioral person is a team member, reports to the primary care physician, but is a team member. So if you're trying to think about a career path for yourself, think about where the money's going. If you're in a foreign country, look at your government. How is your government organizing itself to include behavioral health care? There are your jobs. There's your job pool. Go fishing there. You're much more likely to get something that will sustain you. Because right now, like I showed you, that hockey stick, that's where everything is changing that quickly. Right? Okay, so integrated care is another big keyword. Look for your community, comma, integrated care. Those people will be offering jobs for behavioral health specialists. Patient-centered homes, we talked about that one earlier. Small group and private practices are likely to be squeezed out. The insurance plans are giving monies to the primary care offices. They're following the way the federal government structures things. So let me just give you a little background on that. The federal government health care plans in this country are Medicare and Medicaid. If they approve things, the other carriers generally do it within a few years. They control the CPT codes, the billing codes. Now, if you're in the United States, if you haven't gotten the news that the CPT codes are changing in October, then you're in for a rude awakening, because when you go to bill, if you don't use the ICD-10 code, you won't get paid. And this is the federal government's way of controlling us and saying, you need to be using the right codes because the new codes are much more specific and they'll be able to track what we're doing. This is part of, the Affordable Care Act, right? Affordable care means they have to find out what works and what doesn't work financially. They've fed a lot of money to these federally qualified health centers, but the federally qualified health centers are generally organized under the accountable care organizations. They're replacing managed care organizations. Hope you're kind of following me on this. Accountable care organizations are replacing much of what we already have in place for managed care, because managed care didn't work so well. So now they've upped it, and it's going to be accountable care. How can they hold us accountable? You would think managed care had already tried that. I don't know about you, but I've been under some plans where they approve 4 sessions at a clip, and every 5th session you have to go wait and get in more approvals, right? You would think they tried to control us. It didn't work. So now they're going to change the entire payments, they're going to restructure the entire payment system. They're going to be using the ICD-10 codes, which require more specificity in our diagnostics, but also in our documentation. And if your documentation doesn't follow what you gave as a diagnostic code to get paid, they're going to take the money back. All right? That'll be next year. So we start taking our money back. Oh, $5,000 here with this insurance company, another $5,000 there, $10,000. People will start getting it in our ranks that you need to follow the rules and use the right code and with the right diagnosis. This is how the government's going to make sure that we're following evidence-based care and that we will be working in tandem with other people with diagnostic nomenclature that everybody else understands. So if you're a licensed professional and you like doing aromatherapy, it's not going to fly so well because maybe the primary care doc isn't going to really believe in that, you see, and you're not going to get so many referrals. So this is, I can't go into a whole lot of detail because I don't have a whole lot of time, but loosely that's what's happening. And it is not necessary, a lot of people think, oh my God, this is terrible, terrible. There's a lot more need than, that's why I showed you the earlier slides. We're not doing such a great job in handling the people that need care. So the government is trying this. It's an experiment. Thing is, it's a pretty good experiment because it's based on a lot of research in a lot of foreign countries. So we can expect that we have to be more accountable, that the monies are going to flow differently, and those people who can deliver care remotely through technology will be getting a bigger piece of the pie. So that's more about this. We can expect that we'll be serving more people, and if you have technology, you can do that. You don't necessarily have to have a 50-minute session. You can do a lot of work in a half hour and organize people with self-help materials that are available online. You can do low-intensity care. So many new models are coming about. So I want to encourage you to think about those as you think about really what do you want to do if you're trying to develop a career path for yourself. What is going to be ultimately rewarding? And one thing I'd say to you is if you have a passion for serving a particular population, don't be afraid of specializing in that. The future belongs to the specialists because we have so much technology now to allow those people to reach us that have that. And if you lived in a small town like I grew up in Connecticut, there may not have been that many different categories, groups of people that I could serve as a mental health practitioner. But if I can go statewide and treat them remotely through video, well, gee, now my pool's a lot bigger to serve. So the future really belongs to the specialists. And when you approach primary care offices, if you do have some specialty areas, especially chronic illness, you will be chosen over anybody else. Think about it. That's their biggest need. Make yourself marketable. Give yourselves the skills. So when you write papers, I encourage you, write it with your future path in mind. I went to school with people that did dissertations on empathy training. When they got out, that didn't give them anything. I did my dissertation on smoking cessation. When I got out, I was offered all kinds of jobs because nobody else did that. So position yourself to be marketable, to be able to find a job. This is it's a very different world than when I grew up in it. So I just want to give you some of the things I've seen. So why is online practice proliferating? Now that I've given you sort of the background of this. First off, it's legal and there's ethical. There's not a single law in this country that says you can't do this. I just did a webinar last week. We do a monthly webinar at the Institute, and it was called 7 Irrefutable Reasons Why You Can Practice Not Only Online, but from your home. There are no laws that say you can't do that. No laws that say you can't practice psychotherapy or counseling from your home. You have to do extra stuff, right? You have to really go with your boundaries, not let your kids run in and out of the office. There's the things you have to do, but you can do it. There are no laws saying you can't. This is the same thing of telehealth. You can do it. There are many evidence-based models. I showed you some of that. Also today, the security and the privacy, reliability of technology has increased dramatically. I would encourage anybody wanting to practice in this field to not go with the newest, lowest tech involved. You'll see some people practicing text messaging therapy out there. First off, I've had difficulty with some people when they're in front of me in my office, okay? Never mind if I'm limited to text messaging quick, impulsive things to somebody. That's me, okay? What if they are impulsively text messaging things to me, you see? It's not conducive to how we've been trained. And I'd like to see somebody have taken a course in text messaging therapy. We were talking about boundaries of competence earlier. If they're practicing that way, what's their expertise in doing that, you see? So don't go for all that stuff. Just go for like straight video conferencing where you've got a full set of video, audio kind of clues that you can work with. The cost of technology has gone down. Professional associations have all issued standards and guidelines. Social workers, counselors, psychologists. So everybody, MFTs, everybody has a piece of their ethics code now that talks about the appropriate use of care. This is not rocket science. Anybody can do this. Once again, if you want to work with schizophrenic patients, you have to have more around that patient than just their living room. A medical office is a good idea, or a facility is a good idea. But you can definitely do it. And then I wanted to show you this slide because I'm not sure how many of you are aware of what's going on with Medicare and Medicaid, but I think this slide really says it all in terms of the point I'm trying to make about the future. Last year, Medicare issued a new law that if a hospital treated somebody for a disorder and they released them, they needed to not charge Medicare for any readmission for the same disorder if the patient came back in within 30 days. Now what's the government doing? The government's saying is, you know what? If your systems are so slack that you didn't diagnose them right, you didn't treat them right, and now this person is back with the same problem within 30 days, you have to treat them, but you're not going to get paid. So the government is not just doing this with mental health, it's doing it across the board to improve the standard of care, the better outcomes, to say, you've got to get better, folks. This is ridiculous. We're treating people over and over and over. People come 5, 10 times for the same problem. So then all of a sudden, miracle of all miracles, those people in these hospitals start looking at, well, what's the most frequent reason for readmissions? That's what this study is. You'll see the URL at the bottom where you can dig this up yourself. The second reason for readmission, the second most frequent readmission reason was mood disorders. Are we surprised? The stats I gave you earlier? It's amazing. It's amazing. Look at this. Under Medicare, 20% of the people that were readmitted had a mood disorder. Medicaid, 17%. So the two federal systems. But you would think, oh, the commercial, which is the third-party carriers, the Blue Cross, Blue Shield, Prudential, Aetna, those 10%. 1 out of 10 patients coming through the hospital within 30 days has a mood disorder. What does that say about our system's ability to pick up mood disorders? Now they're starting to notice, and now they're starting to pull us in. And that's why they want us to come in and help them. So, let's see, I'm going to give you another slant on this, why this is proliferating, okay? When you look at what's going on and you ask patients How many of you want to be seen online for healthcare? Over 75% of the people. Consumers want this. Patients want to be treated within the comfort of their own home. If you've ever been very ill and now you have to go to the doctor's office, you've known this doctor for 10 years, the last thing you want to do is get yourself out of bed and go see a doctor, right? But that's our system today. This doesn't have to be like that. So we're seeing in more and more practices, we have telecare being made available. One of my colleagues, somebody that I help grow his business, just got a huge contract by one of the major carriers in this country. And hundreds of thousands of folks will be getting mental health care within the next year using video conferencing. If you follow our newsletter, you'll see that United Behavioral Health Care just came on board with telepractitioners. Blue Shield now offers telepractitioners. Aetna offers telepractitioners. These are names that a lot of us know. But you can't just jump on their panel. You can't just see a person through Skype and then send them a bill. You have to be credentialed by them. You have to fill out an application. You have to use the technology they tell you to use. They help you get set up. It's a different application process, but you can do this work. So there's definitely a big market out there. And like I'm showing you here, consumers really want it. Now, if you look at the counseling world, and in this slide set I'm showing you more the counseling, but psychology has similar stuff, social work has their own version, MFTs, psychiatrists. Every group is looking at technology and where it's going in the future and building it into what's going on. So the counselors want to have a portability system for licensure. That means being able to practice over state lines. Right now, you can't practice over state lines. If you have a license in one state, you can practice in that state. People you treat have to be in that state, typically at the time of the contact. So let me put that in plain English. I'm a California licensed MFT and a psychologist. I might be treating any one of you over video. We're all in California. This is fine and dandy. If you happen to go to Nebraska to see your mom for a week and you can't take it, you need to talk to me, then you can't call me unless it's an emergency. If you're going to kill yourself, okay. You know, I mean, we've always treated people over state lines. Someone calls you, I'm in crisis, okay. But if it's just, wait, I need a therapy session, you're not licensed in Nebraska. You can't do that. It doesn't matter that that person is a California resident. So the laws have changed a little bit, and you have to license where the client or the patient is at the time of the call. And you think, why is that? It's pretty much the same as a driver's license. You could take your California license and you can go to Nebraska with it. If you have an accident, which jurisdiction did you have an accident in? Nebraska. Nebraska is responsible for you, right? People can't complain to your licensing here in California. You're going to get tried in Nebraska. So that's what this is setting up. Now these rules are getting changed. Right now, it's the law. You practice where you're licensed, and if your person you're treating is not where you're licensed, you can't treat them except if it's an emergency. And I mean a real emergency, you know. Not I'm a little upset. So every association has been working on this for quite a while. I showed you the ACA Ethics Code. It was passed in 2013. There's the URL for it online. And it has an entire section of, at the beginning, every ethics code has this. It's a preamble and a statement of purpose. And in the preamble, you know, I put red marks, and I'm not going to read all this to you, like I said earlier. I just want to show it to you. You can look at it at your leisure later, but it shows you how a lot of this is applicable to technology and practicing not over state lines, but practicing with technology. Now, in the ethics code, for the ACA ethics code in particular, this section H is about distance counseling, using technology and social media. So I want to encourage you to go take a look. I do kind of point to some things here about knowledge and the word I used earlier, competency. You see, every ethics code talks about competency. You have to have some training, which, by the way, this counts as training for you, right? I'm training you. So this is a piece of it. And then laws and statutes. So basically that says you have to follow the law. We talked about this earlier. So I just want to show you some of the wording in this so you know what I'm talking about. Every association has their own version. I've listed them here for your convenience. And so I'm going to go through some of these major issues about the ethics, multicultural issues. So I'm going to give you a few reasons to think about that. If you are working in an area where you are in a certain cultural group or a linguistic group, then you may not be aware that the person you're contacting is in maybe the same state, but has a different cultural group, a religious group. And it's your job to do that. So if give you an example. There many in the telehealth literature, there have been many cases where people work in fairly large states, like let's say Alaska, and there are a number of Alaskan tribes that speak different languages. They may have different cultural norms as well. If you present yourself as a professional to that community, it's your job to know the norms of that community. And if you don't, and you're the only practitioner available, then you need to get some education about that. It's your ethical obligation. You can't just say, oh, you know what, I don't really understand you folks, but I'm going to talk to you anyway. You can't do that. You can't just disclaim it. You have to have gone to some lengths. Now, how do you document competency? You document competency by having completed a course. If you're pre-graduate, then you finish your course and you take your exam, and now you've completed your course. It shows up on your, it's been so long I haven't done, transcript, thank you. When you're a professional, you get out of school, then you take professional training, right? That gives you usually a CE, there's a certificate of completion. That is your proof of competency. I had this life experience, that life experience. It can qualify, but don't count on it, all right? Like I said earlier about the alcoholic, right? 20 years of sobriety doesn't necessarily cut it. So the same thing is true here. Another issue about this is the linguistic side of it. You may speak with people who you think understand you, but they don't necessarily understand you. I'll give you an example of this. When I was in grad school, my roommate was going to the law school. A very bright young woman who was in my cultural group and my peer in terms of academic training, and I had to take psychological testing course, and I had to practice on people. So who better than my roommate, right? Captive audience, would you take a test? So I gave her the Wechsler intelligence test. And there was a question on the Wechsler that says something like, if I can remember this, one swallow doesn't make a summer. So I said to her, what does that mean? And she said, well, it's April, so it's really important to not overeat because bathing suit season is coming along. And I thought, what? Never would have dawned on me, right? But then she was kind of a relatively new roommate. Then I learned she was a bulimic person who was purging. She was obsessed with food and her weight and her body, but I would have never known that. Now, this was someone who spoke my language in my cultural group at my education level, living in my house, actually. And I thought, my goodness, I thought that I understood her. If that can happen with a test like that, imagine what can happen if you go into a religious group that doesn't have the type of belief system you have, or a linguistic group. I'm first generation American. We're French Canadian in my family. And there are many words that I learned in school that I would never use with my family because my family doesn't talk this way. So there's a different use of language. And if you're not privy to how the group uses language that you're approaching as a professional, you're not doing your duty. At least take a course in this stuff. Try to get educated about it. You have an obligation to do so. So multicultural and multilingual issues here. And so, here's the ethics code for the ACA, and I can show you one for the APA and NASW. They all say the same thing, all right? Also, if you have websites, your websites need to reflect a diversity of issues. Now, how do you measure some of this? If you want to test somebody with their English language skills, for example, I do this regularly because I hire people from all over to work in our company, tech people generally, and they're very basic tests of English that are for free online. And lo and behold, spoken English is different than reading English. Somebody might read English or write English very well because they went to school, but they didn't have the opportunity to speak a lot. So when you try to give them a verbal exchange when I try to give them a verbal exchange of here's the things we need done, it doesn't get done because they're not understanding me. But if I write it out, they get it. Well, imagine doing verbal therapy with somebody who writes very well, and so you can't assume that they will understand you when you talk to them. Pretty simple when you stop and think about it, right? But a lot of clinicians just don't think about it. This is one of the many areas that if you don't take the time to stop and think about it, your assumptions are going to lead you astray when you work online. So I'm going to go through some of the models. I pulled some things out here about distance counseling, supervision. This is a 2010 study, but back about, 2 years ago, it was the winter of 13, so 2014, 13-14, I decided that I needed to look up telesupervision articles for mental health. And what I found was 500 articles. Could you imagine that? 500 articles for telesupervision in mental health. Peer-reviewed articles. There's a lot of literature out there. So if you're trying to do things like supervision, don't think you're reinventing the wheel and you've got the first bright idea about it. There are a lot of people that have done a lot of work in this area that through simple searches you can find. We made a report of this at our institute, and it's available online. We also see it in these professional associations. There are competencies that have been identified. I'm the president of a group called the Coalition for Technology and Behavioral Science, and we're working on mental health competencies. As opposed to this is ACEs, this is for counselor education, and it'll go into the fact that you need to understand PowerPoint, and you need to understand things that educators need to understand. We at CTIBS, the Coalition for Technology and Behavioral Science, are looking at competencies for practice. What do you need to know? Competencies are made of knowledge, skills, and attitudes. What's the knowledge? What are the skills? What are the attitudes you need to have to properly conduct counseling or psychotherapy, and even medication management for psychiatrists, using video conferencing and other types of technologies, apps and those kinds of things. We need to be aware of these things before we start doing it. There are a lot of very good articles that bridge the technology world and the mental health world. Here's an example of one. So I just want to show you there's a lot out there once you start digging around. So don't believe you have to reinvent the wheel. There's also a lot about HIPAA and what's getting enforced. I mentioned some things about Skype. I want to give you a little more information why Skype doesn't really work out so well. Skype for Business is certainly good, okay, but a general Skype connection requires an audit trail. HIPAA requires an audit trail. How many of you know what an audit trail is? Nobody, okay. An audit trail is if you think about a child custody case, opposing counsel can subpoena your client's records, phone records, right? How do they get that? That thing, those records are called an audit trail. There's a record somewhere in the phone company that says that at 3 a.m., your client called her ex-spouse, right? Now, you don't know the content of that call, but there's a record that the call happened. That's the audit trail. So what HIPAA says is there needs to be an audit trail, and that trail needs to contain certain things, including breach, like a record of breaches. What's a breach? A breach is like a hacking, okay, or some interruption of the contact. So HIPAA is very specific, and it says we need these things. So what this slide shows you is that HIPAA requires a breach notification tool. Breach notification tools are a message to you that says, that session you had with that client, it was breached. So you, the clinician, are in a position to contact the client and make sure that they know what happened, because you have to inform them. That's part of HIPAA too. It's part of the HITECH Act too. You have to inform the client. So you see there's laws that regulate a lot of this. And a lot of us clinicians aren't following those laws. But if something goes wrong, let's say you somehow bill the insurance company the wrong way, and there's an investigation. And lo and behold, they find that indeed you were not seeing this patient or this client in your office, you were doing it over Skype, then, they get to investigate further and further and further. And they can uncover everything about what you did, look at all your records. They can interview people. They can, pretty much like the IRS, right? The IRS finds that if your return gets flagged, everything you've done gets to be examined. The same thing is true of a licensure kind of review. Everything you've done gets to be examined, including whether or not you did use technology and if it was done appropriately, and if not, you will be disciplined for that. This happened to a physician in Oklahoma 2 years ago, and he was literally disciplined for a number of things. Didn't do a proper informed consent. He was treating people remotely through Skype. He was disciplined for using Skype. The decision actually said that he was using Skype, which is a non-HIPAA compliant platform. So you see, he didn't get reported for using Skype. He got reported because that patient died and the family sued. But then upon investigation, all these things unravel and you go, okay, he was disciplined for using Skype, even though the report was not that he was started. It didn't start with the Skype use. So when your colleagues are, cavalier about, we use it, no problem, I feel good about it. Feeling good about something is emotional reasoning, right? We know that. That's not enough. You have to have a real record of things. So I've given you some information here about Skype's privacy policy. You can read that. There are business associate agreements. You have to get now a document from your technology company saying that it is HIPAA compliant. They share the burden of proof on that once they give you that document. And they also share the burden of cleaning up the mess if it was their fault. So get the document. The law says you have to get that if you're a clinician. HITECH talks about you're needing to be aware of the technologies you choose. So if you're using a tablet, a phone, and a desktop, they each have to go through risk assessment, and you have to document that. It's really easy. The government gives you a website. Go to hhs.gov in the United States, and you just list whatever devices you use, and they'll run you through a series of questions to check on. Then you document that you did that. Print that page up and write on it and stick it in your file. So it's really not that complicated, but you have to do it. The ethics code at the ACA does have some information about HIPAA and HITECH. In the legal office you can get that, so you can contact the ethics office at the ACA. You can also get the legal office at the APA and the National Association of Social Workers to help you get your documentation in order. So it's like any other specialty. You have to get some things in order before you do it. So I give you some legal suggestions here. Licensure issues, we talked about. There are certain reports that will give you a summary of every state. So that here's the one for counseling, and it's the state of Alabama is the example I gave you. So they'll tell you what your educational requirements are, what your experiential requirements are, and what your credentials need to be. So in psychology, they have even a more specific one about can you practice in that state without a license in that state? Yes, no. The answer is usually no. What the penalties are if you do, and they vary. In some states, Alabama, Vermont, and Utah, the penalty is $5,000 if they catch you doing that. And or 5 years in jail, depending on the state. So they don't take it lightly. So we have parity for private insurance coverage. So there's reimbursement in a number of states. I'm going to give you a little more information about this. Here's a document from the American Telemedicine Association where you can get a lot of this kind of state-specific. Licensure and reimbursement go together because you're not going to get paid if you're improperly licensed, right? So you'll see a lot of these documents talk about both. Can you practice in the state? If so, what do you have to do? And then how do you get paid to get that work done? There are certain rules. You can't use the wrong technology. You can't practice over state lines. Let's see. And then I'm going to quickly at the end here, I'm going to give you a number of environments where you can get a job that pays on par with in-person care in a variety of settings using video conferencing. So first is nursing homes. A lot of people can't come to you, the nursing homes. The traditional model has been that we go to them. If you know any nursing home type practitioners, well now most nursing home practitioners can sit at their own home and have the patient delivered to the screen by the nursing staff. A lot of times they'll have a computer on a little roll-around cart, and they'll bring it up to the patient's bed, and you can have your contact with a session with the patient. I've had a number of our graduates at the Institute do this kind of work and learned that not all nursing home patients look like the folks in this picture. Many of them are young, and they've had an automobile accident or a motorcycle accident, and they can't live alone. They're too disabled. They can't live alone. And when younger folks go to them, as a clinician, they love to talk to somebody who they can relate to. And they have the same music. Younger people share different kinds of things. So there's a thriving future for people that are interested in this kind of work and want to work from home. A lot of our people are young moms that have a few kids at home, and if someone doesn't show up for a session, then they go throw a load of laundry in, or they help Johnny with the homework, or something else can happen, but right there in their home. So nursing homes is viable. Employee assistance programs are many people that work in certain for employers who have employee assistance programs that now use telepractitioners. And once again, that practitioner can be in their home. There's no law that says you can't be in your home, and you can just get paid your regular paycheck for sitting at home and working with patients. Now, they have electronic health records. These systems are pretty evolved at these companies. But you just follow the rules, and you can do work 2 hours a week or 30 hours a week. It's completely up to you. Rural hospitals, we do webinars at our institute, and we have had some people come in that have set up services from their homes. So a couple of them right outside of LA here, and they service rural hospital communities. A couple of women that I met service the rural hospital in Lake Arrowhead here in California. And I interviewed them for that webinar a few years ago, but they've now gone up to 5 rural hospitals. How did they do that? They just got themselves the right technology, and they started knocking on the doors of these rural hospitals, usually ones in nice kind of tourist towns, so that when they visit, they have a nice place to go to. They're really smart young women. And that's what they do, is they have a telepractice, and they go visit their sites every 6 months. They go do an in-person session with all of their patients, and they network with the local police, and they kind of understand the communities. They have the referral source and their emergency network all in one. It's a very smart model. So rural hospitals certainly can be another place you can practice from your home. A lot of kids are in school. They have a nurse's office they go to that becomes a video conferencing room. They might give you an area, or give the child and or the parents who come into the school an area. So there's a lot of clinicians that do work this way. Specialty hospitals, a lot of kids get traumatized by what they have to go through in these specialty hospitals. Or their residential treatment facilities that use telepractitioners. So they may have you deliver care and follow the patient once the patient leaves that facility. That's a beautiful model, by the way, for telepractice, because that patient was really there for 30 days or something. It's a long time, and then you do the follow-up care. Telepractice is best used in follow-up care, by the way. So what do these all have in common? These groups do the recruiting for you. You don't have to go solicit them. You don't put a page up on a website and say, come and talk to me. They will deliver patients to your desktop. There's usually a physician or a nurse 24/7 in those first environments I gave you. Or for the EAP, it's an employee, and there's a record on that employee as to who they are and what the family, who the family is and all that. So it's not just a person cold off the net. And they're gainfully employed, so in terms of the percentage of people serious with mental illness, it's not that great. So it's a safer population to work with online if you don't have enough support. Patients delivered to your desktop. They usually choose the technology for you. They train you on the technology. They will credential you. They'll help you get licensed in the right states if you want to go in foreign states. And they all use protocols, so you don't just sit around and wing it with people. Another model I like to talk a lot about is migration model. So some people like to get migrated over, use the people they have in their own practice and migrate them to the internet. So that's a very common model. And here's a strategy to do that. Choose the people that are the most stable in your practice and consider the diagnosis. You really don't want to go with a high-risk person. Prepare them a good 3 months in advance. You can plan some in-person sessions. It doesn't have to be all or nothing. You don't have to just, okay, now I'm never going to see you again. You can have them come in 3 months or 6 months and kind of every 2 weeks, whatever you choose to do. And then just keep on with the same protocol you've already done. There are also private companies serving people online. This is where I want to encourage you to be thoughtful about reading up on what they're allowing you to do. I think I've given you enough information here to start asking some reasonable questions. Are you violating any ethics codes, any laws by working with these people and doing what they tell you to do? So be careful about them. We do have a website, providerpanel.com, where we ask you to fill out a credentialing packet. If you're interested in an online job, you can, as a part of our institute, this is a new company we're growing as part of our institute. Our graduates want jobs. So if you're looking to get employed, then we show some of the employers we know your packet, and if they're interested, they will contact you. So I have a list of questions that you can ask online employers. So once again, just use this. You can read this at your leisure, but be mindful about who's hiring you, and ask the right questions. Look for some of these kind of out there. I do have a blog you can look at regularly at the Institute. Telehealth.org is our website, and you can come to our blog, telehealth.org/blog. And let's see, we have a few other risk management kinds of things in terms of other models. Home health is a good one. A lot of telepractitioners are being hired by correctional facilities. A lot of military, VA. The VA is the largest employer of telepractitioners in the country. And college counseling centers, very, very big. And rehabilitation counselors are now being used. For chronic illness, kind of rehabilitation counselors are being used. So with that, I'd be happy to take any of your questions. It's a tough one because you're responsible for that. And the optimal setting would allow you to have a full body camera and then a more close facial camera. But most people don't practice that way. So the normal way to handle it is part of your informed consent is to tell people that you can't do the same as you would do in your office. So you ask for more leeway, that you might end up asking more questions. You might end up asking them to report to you what their body's doing. If you kind of see a little motion, what might that be? And that they ride with you on it. So that if later on you get into a little tussle with somebody, then you can say, remember when we talked about this and the first time we met, I told you I might need to ask you a few more questions. Please bear with me. So at least you have some type of lever there, and you can work with them. But it is more difficult that way. You simply don't have that information. So you can't say, why is your foot doing what it's doing if it's tapping wildly? You don't have that information. I think another way that body language, a little takeoff on that is maybe voice amplitude. If someone sounds really loud in my office, first thing I'm going to think of is alcohol use. Because when people drink, they're not aware of the decibel level, right? And I know that as a clinician, but online, I might just think, gee, maybe my speaker's up too loud, or something's on their end too loud, or something, But you're stuck with that. You just don't have the same tools. That's why, what I was saying at the end is, you can ask people to come in. You can ask people to come in every third, fourth session. If you set it up that way, the way I work is I work with you 2-3 sessions, and then I'll have you come in every fourth session or so. Then you can always forgive them that and say, I don't think you need to come in, it's fine. But for the people who do think it's needed, then you can say, well, that's kind of the way I work, and make it look like it's the normal thing to do. Then you can have a better assessment. But there's no magic answer to that one. It's a really tough issue. With time and the wearables that I was telling you about earlier, and not just wearables, those of you that are pretty techy know that there are some subcutaneous type sensors that are being developed and marketed now. They haven't quite gotten to the level of measuring emotions, but we are about that far away. So give it another 5 years, and you'll see a lot more of that. So people will be able to understand themselves and their insides more than we ever could as a trained clinician. that will alter the therapy we do. And that's why I take my time and energy to help educate groups, because we're not ready for that. But we need to be, because the tech world is. Well, I've been a clinician for 35 years, so my experience with insurance companies has been a long one. And I think that there is a difference in goals. Insurance companies make money if they do not pay benefits. Can't be any clearer than that. We make money if we deliver care, right? So in that it's a simplistic way to say it, but we're working at opposite ends. We will always have a challenge to get the care that we think appropriate delivered and paid for by insurance companies. They are right now being forced by the government to be more accountable, all right? Because a lot of people have looked at the Affordable Care Act and renamed it the insurance, instead of health care reform, health care reform is more insurance reform, health insurance reform, because now they're forcing insurance companies to have documentation for what they do. So it may not happen in my working years that we're going to see an improvement with this, but the entire system is getting revamped. And in the big picture, telecare brings down cost because it gets people to the practitioner's office sooner. So it's a no-brainer that it's going to grow. And it's a no-brainer that insurance companies have to pay. The thing is, they're going to not pay as long as possible, right? So we have legislation now in 26 states that says they have to pay on par with in-person care. Actually, in California, we had a law called the Telemedicine Reimbursement Act of 1996. Did I tell you how old this law is? Okay, 1996. That's literally said, and I quote, face-to-face care is not a condition for reimbursement. Right? We've had on the books for all this time a law that says that face-to-face care cannot be a condition of reimbursement, and yet how many of us have gotten reimbursed? Because it gets blocked at the insurance company. And I had a woman come to me about 4 or 5 years ago, really liked it. I treated her, like a decade before that even. And I really liked her, and she was very high functioning, ex-military, was into the whole video conference. She totally got it. She wanted that. And I applied to her insurance company, one of the major carriers, and they said, no. And I said, well, I don't understand why. Because you didn't do a thorough intake. They said, yeah, I did. I did an hour intake, and here's everything. They hadn't even read my intake summary. Okay. So I said, well, could I? And the guy was like, no, not going to happen. And so I said, could I speak to your supervisor? The same response. No, not going to happen. So I called my insurance company, my professional association attorney, and said, I know there's a law because I teach this law. So how do we get this company? He said, well, you can hire me. It'll cost you at least $100,000, and I'd be happy to go fight for you. Well, I mean, what's the average clinician going to do with that? So that's the battle we have. But what's also happened is that, like I mentioned earlier, the major carriers, they're all coming on board this year, right now. This is when they're coming on board, and they have very large panels that they're rolling out of clinicians. So if anybody's interested in providing care through those systems, then apply to the companies. Ask them for their credentialing packet. That's the language to use. What's your credentialing packet? Very soon, actually, not over time. I mean, over time, but much shorter than we believe. Because the system is getting completely rerouted. Right. So this ICD-10 transition that we've got in October is the first stake in the ground, but the audits that follow that are coming up right behind it within a year, 6 months to a year after that. And then we're going to see that the private practice clinician is going to be getting less and less referrals, and the referrals will be coming through the primary care office, and that's going to be the model, Toby. It's going to be that it's going to be short, brief, focused, and very different than what we're used to. So I'm sure that you can always petition, but my experience, even when we transitioned from indemnity care to managed care, was, yeah, you could petition. 15 forms later, and 13 rejections later, you keep at it. But by then, weeks have gone by, and so there comes this point of diminishing returns if you're trying to struggle to get these things approved. We're not going to have the kind of care, insurance-based care that we've had in the past. What we're going to be seeing is much more self-help, where clinicians will be referring people to get more information online and more brief, intense, focused work that will rely on a video segment, for example. Like a depression treatment 12-session video segment online, and the clinician will bridge the person from session to session, which, if you look at outcomes, that kind of data, looking at those kinds of studies, they're on par with a full-on 50-minute or hour and a half, So who's arguing? The data, right? Not that data's all perfect, but there's a lot more that can be done with less clinician time. My concern as a clinician, because that's what I trained to do, that was my first love, it's exhausting work. In, out, oh my goodness, So clinicians will have to learn to do a variety of things in the practice just so they can keep their own mental health and not do, a full load of just patients constantly in and out. I've heard people talk about working in those integrated care models where it's typically 15, 20 minutes, and whoever comes to the door, oftentimes, if it's the elderly mom who came in with her 70-year-old son, well, both of them come into the session. Well, now you got two people to deal with. You got to say hello to, you got to warm up to, you got to find out what the real facts are if they start arguing. I mean, this is time on the clock, right? Then you got to give them something to do and get them out, do your notes, get next one in. That kind of thing is tiring. It's very tiring. So I think part of the problem here is that not enough of us have gotten in there to talk about these things with these folks. These are models that are getting dictated to us because we're so busy focused on what we have been doing, we're not looking to see what's coming up. So that's why I'm excited to share with you what I see coming up and invite you to go look for yourself. Go talk to people about integrated care. How is that going to work for you? Maybe you need to teach a half time. Maybe there are other things you can do and not wear yourself out with some of this. Or find a real specialty niche that is just your thing, and you get in with a practice that's big enough that they need you, one person, to do just that. There's many ways to earn a living in our field. That's the beauty of our field. There's a lot of things to do. Weekly newsletter is called the Tele Mental Health News, and you go to telehealth.org/ this way for the camera, / sign up. I think it's sign. If you go to our main page, the homepage, telehealth.org, there's a top toolbar and newsletters in there. Yeah. Also, under services, I think we have a drop down that says services that we offer, so newsletters in there. It's a service. And a lot of times what I'll do is I'll blog about some things and I carry a little piece of it in the newsletter and carry it back. So when I write, I try to write about once every week or two, then something I really feel passionate about, then you get the full blurb on the blog. But every week I do go through the mental health stuff that I see come through, and there's a lot. And I'll tell you, over a year ago, it's twice as much now. The behavioral health care, this is the good news for today. Behavioral health care is being seen by pretty much everybody I talk to as the next big growth area because of the numbers I gave you. That's why I gave you those numbers. Those are true. It's the largest unmet healthcare need in this country, and probably in most countries. Yet, we're still doing it the old-fashioned way. When you start to get on board with some of the new models we're talking about here, you can see how a lot more people can be helped. We have a variety. So the question is, what does the training look like at our institute? It's generally for people who are either in graduate school and know they want to do this and want to do this in conjunction with, or after graduate school, but we don't teach you counseling or therapy. We assume you have that. We teach you how to do what you want to do, but through technology. Mostly video, telephone, text, when it's appropriate to do text, like email or text messaging, apps, those kinds of things is what we focus on. And that is available in a variety of packages. So we have either individual courses you can come and just take a course on reimbursement if you're interested in that, or you can take a course on legal ethical. We have, I think, 9 units of legal ethical. So not units, but they're hours. So 9 hours of legal ethical. Informed consent. We need to put in informed consent. So those kinds of things. Then we've packaged it. So somebody wants the DCC training that you were mentioning, Dr. Grimes, earlier, that now they require 15 hours. So we have a 15-hour package. And that, for those of you that are interested, are telehealth.org/DCC. That's kind of easy. Telehealth.org/DCC. And then we have a more intensive program. I believe it's a 42-hour program. And that includes private time with me. It includes a monthly call with me. And the reason I do that is a lot of people have questions as they go. You know, getting set up is a developmental process. It's not like it's like learning how to do counseling. You don't just pop out, you get your degree, and now you're ready. You do have placements, right? So you learn things as you go, on-the-job training. Well, that's what we do, too. So as you do whatever you're doing, we're there to answer your questions and to help you through it. So that's a monthly call. So that's the larger package. And see, my joy is to connect it together. Because how can we bring the right app to the right person with specific disorders? And what about wearables? What about sensors and all that? So I'm just all into that. Well, we're starting a directory at the Institute that will house people that have that. And then what I do on the backside is I introduce them to each other. So I'm sort of the yenta, you know, where I kind of get people together and I help them. Hey, you know what? You have something. You need to meet her, you know, and then the two of you work that out. So, and then I come in with more of the legal ethical side and help both of them, you know, meet that middle ground with something that makes sense. So that's a lot of the consultation I do. But there are thousands to answer your question. It's just that we don't get to hear about it. That's why I decided nobody's done. I'm going to go do a directory. So stay tuned. And we'll be announcing that in the newsletter and on the blog. So if you come to the site, you'll see it. Just video conferencing companies alone, we've had a list of over 60, okay, that are HIPAA compliant. There's a lot of them. There's a new one a week. I mean, that's my new thing. It's like, this is this week's, you know. So they all think that they got the hottest thing. They're all the same. In my mind, they're all the same. I think the easiest way to get at this is the American Telemedicine Association wrote 3 guidelines for telemental health. 2 were produced in 2009. The one that is for video conferencing has all those specs in it. The speed of the videos, which you're asking. So it has that, the sound quality. If you're treating children, how does your room need to be set up? Okay, because children move. You can't just have it stationary. You know, they have to have a camera that does a whole room. Elderly people, you need adaptive devices. So it goes into all those specs. Then both those guidelines disclaim applicability to the internet. So 2009, right? 2010, I start raising my hand. Hey, what about the internet, right? So 2 years I had to hassle these people, and they finally decided to get a committee together to write a guideline for the internet, and they asked me to be on the committee. So I was part of that guideline writing work group, and so that was 2012 or 13. We finally published that. Those documents are the best ones I've seen. I've seen some of the associations come out with guidelines for like telepsychology. Really tough to read. And if you read that and are not scared, at the end of it, there's something wrong with you. Okay? So I'd encourage you to read it if you must. But one of the things we did at the Institute was we compared the American Psychological Association guideline and the American Telemedicine Association guideline. Now, granted, I was biased. I was part of the author team on this. But just to give you an idea, this author team had 30 people, 10 tech, like coming up with those specs. Not my spec. I'm clinical. So they had 10 tech, 10 clinical, and 10 more administrative, like the billing, like the back office management, pick for forms, like all that stuff. And So 30 people came together. At the Psychological Association, they had 8 people, 6 of whom never had any experience with telehealth whatsoever, just because they were APA people, you know. And then 2 who joined, one from the VA, one from the military. Now, that's great, but that's not your average private practitioner. If you do something wrong in private practice, you can lose your house, right? If you do something wrong in the VA, you lose your job. There's a difference there, the liabilities. So the ATA one looked at how do you set up your session to make it reasonable that you're covering all your legal bases. So I'll give you an example of that, and then I think our time's probably up. But the example of that is when you start your session, you say, "Hi, I'm Dr. Mayhew, and I'm speaking with you today from Irvine, California. Would you please identify yourself and where you are?" So they say, "I'm Joe Smith, and I'm from LA." Okay, what have I just done as a clinician? I have established that the identity of the person as they have spoken it, okay, and I write that down, right? Or if I'm smart, I use electronic health record that I can check a box, all right? And if I'm smarter, electronic record, they don't even do that in session, they do it before they get to see me. I don't have to ask it. In any case, that's established every time with every patient. And I also know where they are because are they in my jurisdiction or not? If Joe Smith says, or John Smith says, "I'm in Nebraska," well, gee, John, I'm really glad to see you today, and is there an emergency? I want to know, is there an emergency going on? You know, that kind of thing. No, well, you know, we talked about this. I can't really have a full session with you, so maybe we can reschedule, you know, kind of deal with that, right? That is what that guideline, the American Telemedicine Association, goes through. How do you do this? Why? Because those people have done it, and they know how to get to the point and move on and then have your clinical work done. So that's why we compared at the Institute, we compared those 2 guidelines and give you a one-sheet handout of, you know, okay, we're good to go. So that's what we've done at the Institute, is condense a ton of material into very usable checklists and kind of rules of the road. As far as the technology goes, the end station, you know, where the patient is, that connection can be bridged by different levels of video. So it's not just what's going on at their end, but the connection you choose. There are some video conferencing companies that have what's called better penetration. So it will go into rural areas more efficiently. It's called a lightweight kind of connection, right? So it doesn't have a whole lot of baggage to try to drag through a small pipeline. So there are some companies that are known for that. And if you're seriously looking for that, then you can ask those kinds of questions. At our Institute, we have that. We have a LinkedIn group. You can go ask those questions. And you'll hear from some of the vendors talk about that, all right? Now, in terms of informed consent, your standard informed consent is what you need. You need to have all the stuff you put, which is the issue you brought up, is have you provided the patient or the client with enough information about alternatives to care if they don't want to do this video or phone or whatever thing with you, right? Yeah, you have to do that, but that's part of the traditional informed consent. Then what normally happens is that the informed consent that you have for telepractice is an addendum as a last sheet. And we give you that at the Institute. It was developed by a telehealth attorney, very specific language in that, but it includes things like there will be no repercussions, no negative repercussions if you don't want to work with me. But then you have to think, well, gee, the person lives 400 miles outside of town, you know, you either work with me or there is no clinician out there in many cases. So, you know, it's a formality we often go through, but most people are really not going to be upset about working with you if you're the only show in town, right? So we have to do it because it's part of that informed consent process. I think some people get hung up because they think, well, it's informed consent for telepractice. It's a whole other animal. It's not. Everything you normally do, establishing your fees, it might get worse before you get better, you know, all the stuff we normally talk about, informed consent. What I'm going to do if you try to hurt yourself or tell me you're going to hurt yourself or hurt other people, mandated reporting, all that stuff is there. But it does have this addendum as an overlay. Risks and benefits of using technology is a part of that. Does that answer your question? All right, good. Okay, well, we've had a rousing session here. Thank you for having me. Appreciate it.